My name's Nigel Campbell. I'm a GP from Lisburn. Apologised already for the muddle in this afternoon's timetable. And I'm one of the longest serving LCG chairs now. There's been changes over time. There are 5 groups, as you know. Ours is South Eastern Local Commissioning Group. I practice in Lisburn and I'm the chair of the group since 2009, I think.
Okay.
I'll let you introduce yourself and then I'll make a few comments.
That's grand. My name's Paul Turley and I'm the commissioning lead for the South Eastern Local Commissioning Group. I've been involved in local commissioning for quite a number of years before taking up this particular post. I was also involved with the Down Local Health and Social Care Group and the Lisburn Local Health and Social Care Group, which were the forerunners to local commissioning groups, and they were in place around about the early 2000s.
And I go back a little further than that. You were involved too. I think Commissioning Pilot was an entity before the local health and social care groups. I was involved in that in Lisburn. Lisburn was one of the fledgling commissioning pilots at a time. I was just going to mention a few areas where I think we differ, or a few things that are different in our particular area, and then to do with emergency care and A&Es. Ours was the first area to have reduced opening A&Es, or emergency departments, in Downpatrick and now in Lagan Valley also. We were the first to have joint accident emergency A&E departments alongside out-of-hours services, so GPs and A&E services working together in one area, one unit. We're the first to add in minor injuries unit into that mix. We have that now in Downpatrick, where we've got GP out-of-hours, nurse-led minor injuries unit, and a daytime accident and emergency service all combined. And you may want to ask us more about that. Specifically, we have interface issues. I know all of us have interface issues, but in our area in particular, with South East and Belfast, we both came out of one legacy board, the Eastern Health and Social Care Board, and we still have some issues that flag up from that. In our A&E services, the closure of Belfast City Hospital, A&E, in 2011.
October 2011. Yeah.
In 2011 had great impact upon our services provided, because our primary hospital is the Ulster Hospital in Dundonald, which actually is within the geography of Belfast LCG, even though it's counted to be South East LCG. So we do have specific interface issues with Belfast. I think that's all I'll say by way of my introduction. If you want to say a few.
Just in terms of the South Eastern LCG, maybe Bride's covered it and Paul Cavan in terms of their overview of their own LCG areas, but I suppose our LCG covers the South East, as Nigel has said, so we're covering the current local government districts of North Down, Ards, Lisburn and Downpatrick or Down. We've got a population of about 340,000 people to, I suppose, cater for in terms of their health and well-being. So there's quite a responsibility around that. And as Nigel has indicated, when it comes to unscheduled care or emergency care, we have this interface with Belfast around the Ulster and the Ulster Hospital in East Belfast. So that population would access services from the Ulster Hospital. So there's quite an overlap in relation to that. So potentially there's a population of 444,000 which need catered for in terms of that interface with the South Eastern Trust on unscheduled care. Obviously, we've got a mixed community in terms of the geographical outline. Obviously, we've got an urban area to deal with in terms of the Belfast area and around Lisburn and North Down and Ards, but also quite an extensive rural area. And I hear the issue of rurality been mentioned in today's discussions, and that's an important issue for us as a local commissioner. I suppose in terms of the membership of the LCG, 17 members, I think, have been mentioned, so we've got a good range of members, and we've had excellent participation within our LCG in terms of the membership. May not be the case in all LCGs over the last while, and obviously there are time commitments from a lot of the individuals who need to be included in that group. But I think we've prided ourselves that in terms of the commitment, we've had a very strong commitment from both those executive and non-executive members of the LCG. And I would point particularly to the GPs in the area who've been made very strong commitments to the LCG, and those voluntary and community sector reps as well. Another important contributor, I think, around the table has been the councillors and the council reps. And again, we've had a very strong participation from council at LCG and in our own ongoing discussions with councils as an LCG as we've gone out and engaged with various aspects of the community. So I think that's been a very positive aspect for that, for us from our point of view. In fact, Lady Silvia Herman actually attended one of our LCG meetings, I think towards the start of the year. I'm
Sorry, could you say that again? I didn't catch it.
Lady Sylvia Herman, who's the
Local
MP
MP.
for North
North
Down,
Down,
and I think that was her first opportunity to visit and to meet with at LCG in terms of our public meetings, because as Brian was saying, we have a monthly public meeting which is open to the public. She came along to one of those things. She was very impressed, and she made a statement at the end of the LCG meeting about the opportunities that LCG public meetings give the public to come along and contribute to the debate around health and social care, and to listen to the discussions that are going on and those commissioning discussions that are going on around the table about people's health and well-being needs. So it was very useful. I think there was some reference today to staffing as well, in terms of us being an entity or a committee of the board. I've mentioned about the 17 members who are around the LCG table. I suppose I manage a small team who are associated with the LCG back at the board, and we are actually based in Lennon Hall Street in the board headquarters. We're the only LCG that isn't based in its own geography. And we've toyed with that as an issue. It's not for lack of trying. But actually, if you look at our a map of the southeast, actually Belfast
is pretty central.
In terms of Lisburn, getting to North Down or Ards, or getting to Downpatrick. So we live with it. We live with it, I think, as an issue. But as I say, we have a small team who I work with in terms of the LCG. But then we do have access to a range of other professionals who are with the board and PHA and support us in the work that we do, which is very helpful. So maybe I'll just finish at that point in terms of any questions that you might have.
I have a couple of questions. When we met the South East Trust, I think fair to say the evidence we got, and on the record from the Chief Executive on, for example, the 4 and 12-hour targets, he was very candid and said, in effect, that those are the targets, and those are the targets obviously we have to provide data for, etc. But as far as he was concerned, they were not a measure of quality. In fact, he said, we've developed an alternative quality performance that we think is much better measure of actually whether we're providing a good service. So, you know, if we had lots of trolley waits that were 11 hours long that met the target, that wouldn't necessarily be a quality service. Now, I'm conscious then in terms of local commissioning groups and board who commission and ministerial targets, and all of this is meant to be seamless and dovetailed. And that struck me as an example of where something has gone wrong between kind of ministerial targets and all, we've got lots of layers here and potential of sort of communicating downwards. And I wondered, from a perspective of the local commissioning group and sitting from a position of the board, having targets on the one hand, which I know come not from the board but from the department, and having a trust on the other hand who is saying, well, we don't think those are the right measures of quality. Where you sit then in terms of how that kind of disconnection between a kind of top-down and bottom-up happens in practice, and whether you'd have any comments on that as an issue.
Yeah, well, I'm happy to start, and Paul can finish off, because I listened to the debate there with Bride and the Northern team and Lawrence. It's a fairly blunt instrument, the 4 and 12-hour targets, and I think everybody will admit that, and that has come down from above, as you say. Needless to say, we've had a lot of discussions with the clinicians in secondary care, both primary care physicians meeting secondary care physicians, especially looking at our model choices within South East and the new model between out of hours and A&E. And our problem is that we are trying to apply blunt targets to very varied groups of people coming through one particular set of posts. And I think that's one of our problems over the years, is that we have funneled all admissions to hospital through our A&Es. And that goes back from when I qualified first. There was a lot more GP admissions to hospitals, and then it became easier and convenient for everybody that they all went through the one admissions door, which happened to be A&E. And now I think we're beginning to separate that out and see, is there not other ways we can get people into hospital? Because we could have, in those 4 12-hour targets, we could have an elderly grandmother who's got a urine infection, needs a few days in hospital, doesn't need full resuscitation, lying next door to someone who's just out of a car accident with broken bones and a head injury, next door to somebody who's had a bee sting. And it's inappropriate to apply the same target to all areas. And I think part of our challenge is trying to disaggregate that, and that's where we're looking at our minor injuries units and GP out of hours and our unscheduled care plan, effectively.
I suppose the issue was, I didn't, I mean, and in fairness, I'm not sure that the chief exec of the South East Trust, I think he was much more upfront about this. I think there were possibly hints in other evidence we got that that wasn't a view that was an isolated view, but it still struck me as there is something in a system which is meant to be interlocking, disconnecting between, if you like, what those on the ground at the kind of management level were saying represents quality, and what was coming, if you like, from down from obviously department and board, because although it's a departmental target, and I know it's a kind of beyond Northern Ireland target, there still seemed something with all of this consultation and discussion that you had something as fundamental as how you measure quality had led to a difference of views, and it hadn't been resolved as to, well, how do we then tease out what that means in practice?
If maybe I could, if I go back maybe quite a number of years before we had the regional board and local health and social care groups or local commissioning groups, I think the board did have more conversations maybe with trusts around the quality aspect of issues, and that happened on a fairly regular basis. But certainly in our discussions as a local commissioning group, with the trust and with trust clinicians, I think we've been in a position to listen to that quality discussion about how they're implementing quality throughout their service. And it has been reassuring to us as a local commissioner to hear that the clinicians are spending time with patients and that they are putting quality to the front of the agenda when it comes to patients coming in through the front door and through the system as well. And maybe the board is pretty numbers focused in terms of its performance management and its monitoring arrangements with the trust. But I think in the past we've had the opportunity as a local commissioner maybe to have that more in-depth discussion. Maybe we've got more time as a local commissioner in terms of them coming along to our meetings and giving us that overview about the quality aspect of their service. I think we've also been keen to pick up on it. I heard 10,000 voices mentioned earlier, and I think that's a very dynamic system potentially. We were very keen to tap into that as a system to hear about the patient's voice and how that actually comes back in terms of the service that's provided to patients whenever they enter the system, the Southeastern system. So again, we've had presentations to the LCG around the 10,000, and as a system we would want to use that to look at quality as we go forward with our provider.
We've had a number of other reports from the Patient Client Council. I assume you've maybe met with them as well. And they do a lot of work and work with us and often attend our meetings to tell us what they're hearing out amongst the groups that they have contact with.
That's right. I've had an opportunity on a number of occasions actually to go and meet with the Patient Client Council. They have a local advisory group which is focused on the South East, and I presume they have one that's coterminous with the other trust and LCG areas. And on the back of my engagement as the commissioning lead with them, we invited them along to the LCG. And there's quite a number of them on the group, so it was good to have that interface with our larger LCG membership. And they've been back now, I think, on 2 occasions, not just to talk about the unscheduled care agenda, but obviously there's a wide agenda in which patients can contribute back to, whether it be mental health services, primary health care services, a range of different things. So that's a very good conversation. And we heard lots of stories about good things and also not so good things as well. And that gives us an opportunity to go back on those issues then, I think, with the trust. The other thing that we can get slightly more involved in recently as well is around serious adverse instances, which of course are quite strictly monitored. And beforehand we didn't really get an opportunity to look at those and to dwell into the detail of those, but more recently LCG chairs and leads have been given the opportunity, and those reports are now shared with us in terms of patient experience, and that's quite important. I think that we now have that, and without giving too much detail of course to our LCG members, it gives us an overview of maybe where the pressure points are in terms of quality within a system like the South Eastern Trust. Previously
we were informed if a serious adverse incident directly affected something we were commissioning or doing, but we wanted a broader view of what sort of things are coming into the system as issues in our area, and we felt if that wasn't coming our way, then how can we address these issues fully? So that is shared with us now each month. We get to see all the serious adverse incidents, even though it may not be something that we're particularly able to do much about, but at least we know what the totality is.
Okay, final question for me, and then I'll pass it to Paul. one of the observations I think we've had from the public hearings is that, and you might want to disabuse us of this notion, but is that we've heard good practice in every trust that's given evidence. And a very good example is the South East Trust, which in the Dundonald Hospital in the emergency department, one of the things they had done was take on a sort of 24 hours, 24/7 basis, a couple of staff who were there, who were not nurses in the emergency department, not clinicians, but were simply staff who were trained up to simply check how people were, check if there were any issues, everything as mundane but important enough as where you can go and get a cup of tea, or do you need some assistance to get to the toilet, etc. The things that sometimes get missed because hard-pressed nurses and other clinicians are moving on to the next thing and pick up perhaps that then somebody was promised some pain relief and didn't get it, and you can go then and just check what's happened, etc. And it seemed from the feedback we'd got actually from then a couple of patients, that had worked very well. We then heard effectively in other trusts from people whose experience was very poor because the pain relief they were promised never arrived. Nobody was able to take them to the toilet, and they were in a position where they couldn't get there themselves. All of those things that the South East Trust, with this one innovation, had done, had made an enormous difference. But I got no sense in which that, for example, good example, was being rolled out elsewhere. And by the same token, we heard lots of other good practice examples in other trusts, which we didn't get a sense in which they were being rolled out elsewhere. So I suppose my question in terms of the local commissioning group is, and perhaps to give, and you took sort of big scale examples of the minor injury unit and what's happened in Lagan Valley and then down, but is how, and perhaps give me an example of something that you commissioned that you then saw rolled out in other trusts, and something, for example, that another trust did that you thought that was a really good idea, we're going to roll it out here. Just how that works in practice with some examples.
Yeah. I was going to mention sexual health and the dermat. I was interested in Brian's analogy around the dermatology project, which is similar to the dermatology practice project that we are running in the Down area. Slightly different model, but again, it's about giving GPs more ownership of the patients rather than sending them up to secondary care. I think there's a lot of procedures that GPs, if given the right commissioning arrangements to put in place with them, can provide services in primary care as a patient's accessing secondary care. So I think, again, that's a service which we have flagged up, and I know that the Northern LCG have also promoted one as well, and I think there's an opportunity for evaluation around those particular models, and I would be very keen, actually, that the evaluation takes place together so that we can obviously judge them, because they're in the same space, as it were, in terms of primary care provision, and look then to have those particular services rolled out. There's another service as well around DEXA scanning, which we've locally commissioned recently, which I think has opportunity for further application. And it's rather than patients going up to the Ulster Hospital to see a rheumatologist around orthopaedic issues, there's an opportunity for them to be referred directly to a DEXA scanner service in Bangor Hospital, which bypasses them having to go to the consultant, and then that can be read by the GP, and then they can be dealt with within primary care, or else they can go then to the consultant if that needs be. So that cuts down the patient journey quite a bit. We would be looking after evaluation of that to see if there's opportunity to share that out with other LCG areas. Quite a big scheme, though.
I'd like to mention sexual health, because that's something that has developed in our area that we're very proud of, and other areas are looking to share in that. It's had the backing of several different groups and clinicians. RQIA did a review of sexual health services and recommended much of what we're doing in South East. We have a very interested clinician in the area who has helped lead on this also. And one of the workings of that is a service for asymptomatic screening of individuals who feel that they may have contracted an infection. The time was when people queued up at the Royal Hospital, level 3, level 1, for an assessment, and it was done behind closed newspapers so that nobody recognised anybody else who was there. Things have changed a lot over the years. A lot of patients now ask for screening because of fear that they've picked up infection in the past. And this service, which has started in North Down in the Bangor area, is where patients can receive that service from their GPs. And then the hospital services, which would have provided this in the past, only deal with those who have complications or those who need more specific treatment. So it's a new pathway of sexual health services, with a lot more of the simpler stuff being done in primary care, leaving the complicated stuff and those patients who have contracted AIDS, as an example, to attend the hospital services. There's been good things about it and bad things. The good things about it is that it's a great service. We're keen to roll it out right across our whole region, and we're doing that as we can manage the funds to do so. So we're into a third area just now.
We're training
out of
GPs
4.
in the Lisburn area at the moment. We've already trained the GPs, and it's in place in the North Down area. So it'll be an incremental approach as the funds become available.
But on the frustrating side then, and this is where there is a challenge between regional and local, the region is looking at this service and say, oh, we want to develop this right across Northern Ireland, why is it confined to South East? Then they're saying, well, that's going to cost, if that's what it cost you in South East, here's what it's going to cost in the whole region, and we can't afford it. So then the frustration is, are we held back in what we do in South East, in our innovation, because we can't afford to do this regionally? So there is that frustration also. And the final point that I would make, which is more a general point about taking a scheme from elsewhere and applying it locally, often there's nuances in the way that the service is delivered, and sometimes picking up a service from another area and trying to apply it in your region doesn't just quite work. We've not got the same personalities, not got the same people delivering the service, and there can be very subtle differences in just patient pathways and what patients are used to and what patients will accept. That can cause a service to flounder in one area that flourishes in another. But those are things that we're used with and want to pursue. The sexual health is one that we would like to see delivered out more quickly.
Okay, thank you.
Paul, thanks a lot, Nigel and Paul, for short notice joining us. I haven't, perhaps it's a good thing, I haven't read your commissioning plan.
We're very relieved.
So may I ask some questions, nonetheless, about it, and I can look at it later.
Okay.
They're really following somewhat on Les's remarks about quality. You see, from the human rights point of view, the quality is really important. In all the human rights literature about health, quality will be there. Quality is really important. And then another really important thing from the human rights point of view is equity. What are the outreach programs for disadvantaged groups? Another really important thing from the human rights point of view is participation, actually, which is why I was banging on earlier about PPI. So let's just stick with those three things, okay? So then someone like myself comes along and looks at your local commissioning plan, and through a human rights lens, I would be looking for, this looks brilliant, fantastic. These probably 17 heads, they hit all the right buttons. But where is the commissioning group making calls on the trust to meet certain quality measures or to ensure quality in its services? And looking at it from a human rights point of view, I'm thinking to myself, fantastic, all good stuff here, but where's the equity built in? Which is why I was asking Bride about the deprived groups.
Yes.
And then I flicked through and couldn't see them. They were sort of mentioned at the beginning and then they evaporated. And she replied to that, and I understand. And then from a human rights point of view, looking at that commissioning plan, one's looking at participation. So not your participation. I mean, I'm quite persuaded by your participation. And I have to say, looking at a lot of the trusts, it's clear they're doing lots of PPI, but then, which is brilliant. But looking at a commissioning plan, one would, from the human rights point of view, you'd expect it to be there. Do you see what I mean?
Yes.
So I will read your plan in due course, but I'm interested to know whether it's in the plan or not. How do you anticipate that your trust will deliver on quality? Well, you've dealt with that. Equity issues for disadvantaged groups and participation.
Yeah.
I do equity, you do participation. To do a bit of both. I listened to the question to Bride and I was scratching my head thinking, how am I going to answer that when I'm asked? I think what she was trying to say, and I would agree with, is that there is a sense that a lot of these things are implicit in all of the plan, that right at the outset of the plan, anything we do, anything we commission has to be quality assured. And any new service that we deliver needs to be a quality service. And we've talked about that a little bit already, maybe I'll just leave that. But on the equity side, yes, growing inequity concerns us. So at every point where we seek to commission a new service, look at a new pathway, at the start of that we're saying, well, look, we've got this inequity in that area, and we know which of our areas are the poorest ones or the deprived ones. We're told from our contacts around our own table and the people that we engage with where specific issues lie. So in the services that we try to develop, or schemes that we try to come up with, we have that implicity there. I accept your point that maybe it's not explicitly stated, but it certainly is implicit to all that we do. I also agree with Bride's point in the sense that there's wider determinants of this inequity, and sometimes that challenges us because it feels like we're the only ones in health who are doing anything about it, when there's so clearly many other things that could be done.
Absolutely.
Now that is one of the big advantages of having local councillors around our table, which doesn't exist at the board. So it's one of the advantages of local commissioning groups, because we have had interaction with our local councils who are responsible for leisure services. You know a lot more about all the detail of this, Paul, but we meet with them regularly, and we're trying to tap into the work that they're doing in the public health space, which doesn't really exist at the board, I think.
And when Nigel mentions the councillors, the elected representatives who are around the LCG table, I would take it to another stage as well, because I have an opportunity working with my health improvement lead with PHA, who has a specific responsibility around that, to actually meet with council officers. So if we're talking about stroke and stroke rehabilitation, there's opportunities for leisure services, for example, to get involved in that part of the patient pathway in terms of recovery. So, you know, those linkages are there, and we try to exploit those as best we can.
And I think that has been one of the boons of the LCG, because we didn't have that closeness working with local authorities prior to the LCGs.
But Nigel, I mean, I completely accept that the social determinants, that they include health sector and social sector, but they go way beyond. So I completely understand that. The health sector alone can't crack social determinants. But nonetheless, in your plan, there's some things that could be done and are being done, actually. You know, in a way, I think you're selling yourself short, because some of these things are being done, outreach programs. But to make it implicit when it's equity and so important, I'm just a bit puzzled by that.
Again, I would maybe leave it through our commissioning plan to look for that.
Well,
I do take the point.
Well, I think Bride made mention, I think, of the family nurse partnership in her presentation, and I think that's a very good example, because we've got, actually I think we're one of the least deprived LCG areas, but that's not to say that there are not pockets of deprivation very much within our overall geography. If you take North Down, for example, obviously it's probably one of the most well-off councils in Northern Ireland. There are some real pockets of deprivation in North Down, and again, going back to that sexual health example, targeting the population who would probably most need to use that, young people in particular, who maybe live in some of those more depressed wards within the North Down area. If we can roll a service out from the centre, which might have been in Belfast beforehand, to GP practices, which are our practices, which we know our practice, and we're quite keen to improving accessibility in that way, well, I think address that issue around equity and access to services, and will benefit those people who are potentially in the most deprived areas. I mentioned the family nurse practitioner. Again, that was a service which is very much targeted in one particular community this time within the South East, which would be what we call the Colin community, which would be on the outskirts of West Belfast, but is actually in the southeastern LCG area. And again, putting that service targeted in for that very clear population is an approach by us as commissioners to target services for that aspect of our population.
I think you're right. We do sell ourselves short on this. When I think about it, in our deprived areas, we have invested. There's health improvement workers who work in Old Warren and Hill Hall, and that's the trust to employ them. But so there are specific thrust into those deprived areas to try and improve that.
I was just going to come on to that point, actually, just about community health development workers, which we commission as an LCG. And we commission them differently, actually, in different geographies. So in Lisburn, the PHA employ them, and it's straight in through the PHA. But in Down and in the Ards area, we actually commission those through one of our voluntary sector partners, who would be East Down Rural Community Network, and they employ them on our behalf. But that is very much a partnership, because they're co-funded with Down Council. So you have those individuals working with villages and village communities around health issues like mental health, suicide, sexual health, obesity, smoking, a whole range of health agendas, and those issues are going down into the heart of those communities, and mostly, obviously, they're targeted on deprived areas and deprived sections of the population.
We've had a peninsula project. We have a project of a group of people who work down in that area
around palliative care.
And palliative care.
So
yes, we have examples. Yeah.
Okay, thank you.
And maybe
you understand
I think, Paul, your third point was around engagement and PPI in particular.
From the human rights point of view, one would be looking for, well, where are the quality requirements, where are the equity requirements, and where is the participation?
Participation, absolutely.
And when they're absent, that doesn't mean they're not being addressed. It just means they're a bit vulnerable, if they're not expressly there. But I won't flog it. You get my point.
I do. But I remember a couple of years ago, whenever I was sitting down, because it's always a daunting task at the start of the year to sit down and write your local commissioning plan. And I remember the first section that we said we would put in as our first section participation, involvement and equity, and we will build the LCG plan around that paragraph. Now, obviously there's various iterations, and you've heard how the plan is developed by the local commissioning group and is shared around the board, and it changes. But I think if you do, Paul, get a chance to look at our plan, you should absolutely find the whole involvement thing right in there, and we have been very proactive around involvement. I was just looking actually before we came across today, just in terms of the events. We've had 4 events within this last calendar year specifically around PPI and involvement with carers and users around various aspects of health and social care.
I think I might be being too boring about this, but it's not your PPI that I'm actually worried about.
All right, okay.
What I'm interested in seeing, but look, let's drop it. I think you have my point. I'm interested in seeing whether or not you effectively are funding the trust to do PPI and requiring them to do it in the commissioning intentions.
Well, I suppose obviously it's very much to the fore in everybody's agenda, I would hope, and certainly I get the impression in discussing with the trust that certainly they're very much engaged around the PPI agenda. We don't fund them specifically for it. I mean, I suppose we commission services, and whenever you tot up all the services, then some of it goes for corporate issues, and PPI would probably fall under that kind of section.
But
we do require it from
Section
them,
75.
Oh yes, all of those issues around. They would fall to their corporate side of the house and their corporate management to look after all of that, but they should be ingrained across all of their work and all of their directives.
Yeah, ingrained but not invisible.
Yeah.
Not
invisible.
Ingrained.
Not invisible. Oh no, it shouldn't be.
Mainstreamed, but still.
It
I respectfully suggest it would be good if they were explicit.
Well, I'm sure over the last number of weeks you've spent quite a number of time. I know you've met with the South Eastern Trust, so I haven't heard the response in relation to that issue, but I'll maybe follow up.
Okay, I know we have to close very soon. Do we have to close right away?
No.
Okay. You, Nigel, I was really interested actually because you underscored a point that had crossed my mind about how you've got these local elected representatives sitting on your local commissioning group, and I think that's really rather interesting. And I'm sort of juxtaposing this composition, because I've got the composition of the Northern Local Commissioning Group in front of me, and I suspect yours is very similar. Yeah. I've got that in front of me, and I'm sort of juxtaposing that with the Trust Board composition, where they've got 6 non-executive directors. They don't have, you'll correct me if I'm wrong, but they don't have sort of built into the system, as you do here, local elected representatives. And I'm just, I suppose I'm just wondering whether or not there are important, good participatory lessons to be learned from the LCG and its composition, which might be transferable to the. You're smiling. I don't know why.
Well,
whether they might be transferable to the trust. Yeah. I'm looking for ways of enhancing the participation of health professionals. That's important. Patients and the public in the health system, so it's not too top down. So are there lessons in the composition of the LCG which might be useful for the trust boards?
I think there is. Ours is the only board that has local elective representatives on it. So if you look, well, no, PJ has.
No,
sorry,
we yesterday, Paul, I think.
Oh, sorry, in terms of local commission groups, we all have.
Oh
yes,
sorry, but
you're talking about
I
the
meant
board's board.
The board doesn't have local.
No, the boards don't.
And
No,
the
the
trust
boards don't.
boards don't. I think there is important lesson. Now, this was 2 ministers ago. It was his flagship, where he wanted local councillors to be involved in local commissioning. He wanted the PHA set up as a separate body as well, and I give him credit for that, because I think that has worked. Now, jointly with the trust, we meet with the councils, and we've less of them than the Northern Board has, or the Northern LCG has. We've 4 down now to 2 or 3 coming. But we meet with them jointly, but it's more of a challenge meeting where they will say, what are you doing about A&E services in your area? Trust, and we're there as a commissioner to pick up on some of the questions too. I actually think working together is a good relationship within the LCGs. We get to hear what they're doing, they get to hear what we're doing, we share thoughts, we come up with joint ideas. I'm smiling as well.
I smile because I suppose the councillors can be fairly colourful individuals, and as a manager, I mean, I do feel a real challenge every month whenever I have to present and discuss unscheduled care issues and a range of other things, because I wouldn't so much say that they actually take it from a party political point of view. In fact, that has really been absent from the discussion. It has really been in terms of their communities. They do sometimes land on individual points about constituents, and that can be helpful up to a point. But I think in the main, they make some very constructive points across the range of comments that they make. The other group that I would actually point up as being very, very useful is the user participation and the user rep, because we have 2 user reps as well, a voluntary sector user reps on the LCG as
voluntary community reps.
Correct.
Right.
And those individuals, I think, have been excellent as well in terms of the
useful
contribution that they've been making just around the services generally, because obviously they're coming from a user and a voluntary sector position on that. Nigel makes the point, I suppose, about the additional work that we've been doing specifically with not just the councillors around the LCG table, but actually going out again, comes back to engagement and meeting with the local councils. And that's been very constructive for us. And I think we had an opportunity last year around the Down Hospital and Downpatrick in particular to have a conversation with MLAs actually and with the MPs for the area, and it was a kind of a doors closed conversation, because big changes are going to have to happen into the health service in the future, and I know there's a very strong political lobby and a political agenda, but I thought it was very important that Nigel and the LCG members had an opportunity to have some frank discussion about how things might change in the future. And I think,
and you'll appreciate how acute that could have been, having a minister who was then from Lisburn, changes in Lisburn, and local council in Lisburn. So
now we have one from Down.
And now we've got
yes,
yes. Okay. So thank you, gentlemen.
Not at all. Thank you very much.
Thank you. That's been really helpful. I actually would welcome if we can get your. And I'm sure Paul
will do that.
Yes, I'll forward a copy. Again, as I think Bride was indicating, everything's in draft, given the situation.
It'll be taken on that basis.
But I'll forward a copy of the South Eastern Local Commissioning Plan to you.
And if there's anything else you want to send us in addition to that would be very helpful. But is there anything you would like to say in kind of final remarks, or to anything you either?
Maybe I'll just make a comment or two. I mean, if you are interested in terms of some of the papers and discussions that we have around the LCG table, you might find that interesting to actually look at our minutes, which are on our website. We're a portal of the regional board website. So you'll find there all our engagement events, and you'll find the minutes from our LCG meetings. And when it comes to unscheduled care in particular, as part of my monthly report to LCG members, it's a standing agenda item in terms of my feedback to members. So we're very focused on the unscheduled care agenda, and have been for quite some time now in the South East.
Thank you very much.
Okay.
Thank you.
Thank you. Really appreciate you coming at very short notice and in a somewhat thorough manner. So thank you. That's been really helpful.
Excellent.